long answer questions. So this year when I had corrected the prelim examination, in that I was one of the examiners as well. The questions were in KM. They had a lot of questions from these Gynec cards. LAQ थे उसमें, and that is what I'm going to be discussing today. It is going to be a elaborate discussion. It might take a while, but I can assure you that once you're done with today's session, nothing else can shake you from the concepts of the three topics, 2 to 3 topics that I shall be discussing with you all today. So, welcome to today's session and let us begin. I hope there are at least 2 people. I hope Dr. Akansha is recording the session, and if not her, there are a few more who are recording it. So, should we begin? Am I audible enough? I hope I am audible enough. Okay. So the first question is going to be a short question that I shall be starting off with. A short question. By short question, I mean the discussion is not that elaborate. So, but there are a few concepts that are present in it. So the question is, it's a first question for the day. The question is, it's a 25-year-old female. Again, as I mentioned yesterday, 25 is just an arbitrary number that I have chosen here. It can be anything in the reproductive years. The intention here is कि कोई भी reproductive years की औरत, especially in the younger side, on the younger side of it, like below the age of 30, but it can be anything, right? From the age of 13 to 45, anything. So any reproductive age group, female. So that reproductive age group female has come to my OPD, and her complaint is that she is having amenorrhea. The amenorrhea is there since 4 to 5 months. She also mentions, when I elaborate further, that prior to the amenorrhea wasn't sudden. For the 1 year preceding that, 1, 2 years, or maybe a few more months preceding that, the menses initially had gotten scanty. So, history of even scanty menses prior to that, scanty, or what you can also call as hypomenorrhea. Hypo is basically reduction in the flow, also reduction in the number of days of blood flow, and also a reduction in the quantity, the volume of blood loss per day through menses. So for scanty menses prior to those months of amenorrhea. Apart from that, she mentions that she is married since 3 years now and has been trying to conceive for all those 3 years. Her and her husband are cohabituating for the majority of those 3 years, and yet they are not able to conceive. So they are married since 3 years. She's trying to conceive. And she also mentions that recently she has had slight weight loss. Now, a few people might have already guessed कि ये क्या case है. Very easy to guess. Guess the moment I mentioned it, weight loss. Weight loss से बहुत सारी चीजें इंडिया के अंदर तो क्लियर हो ही जाती है. बट डू नॉट एक्सपेक्ट कि हर एक एग्जाम में ये ऐसा आने वाला है इसमें वेट लॉस. कुछ एग्जामिनर्स माइट, और फ्यू गायनेक कार्ड्स माइट बी वेरी जनरस एंड दे माइट वेट लॉस है, कफ विद एक्सपेक्टोरेशन है, सब कुछ है. But the ground reality is most of the women are not going to be giving you this history, and most of your exam cases also may not have this history. All the history that you shall have is going to be what you see on the screen right now. This, when I'm talking of it, ठीक है, how do I approach this? First of all, my diagnosis that I'm looking at over here is again infertility, or what I yesterday explained, the day before yesterday, I explained it again. It was subfertility. Don't worry, though, I'm not going to be discussing about fertility again. The topic of discussion is going to be something else. I've already discussed infertility in detail the other day, so I'm not going to go. The first point, the important point over here is reproductive age group female. है. So when I say it's a reproductive age group female and in her peak reproductive years, as in the third decade of her life, ऐसा भी नहीं है कि उसका age 35-40 हो गया है. So very unlikely that it is probably because of depletion of her ovarian reserve. Her ovarian reserve probably has no issue at all. And she doesn't have any issue, no issue with her ovaries. So it is very likely that the ovarian factor infertility has been ruled out. Indirectly, I cannot be sure. Obviously, I have to be testing for a few things. उस दिन मैंने बताया था ovarian factor infertility के लिए we have to do a test called as AMH. AMH is anti-Mullerian hormone. Along with that, you also do something called as antral follicular count. That is a test that you do on day 2 of menses, in which you count कितने follicles है जो अगले साइकिल में प्राइमोर्डियल फॉलिकल से पहले वो फॉलिकुलोजेनेसिस होगा, उसमें से एक डोमिनेंट फॉलिकल बनेगा, बट ऑन डे 2 व्हेन देयर इज नो डोमिनेंट फॉलिकल, सो कितने फॉलिकल्स पर ओवरी है वो भी देखूंगा. इसको हम कहते हैं एंट्रल फॉलिकुलर काउंट. सो बेसिकली द फॉलिकल जिसके अंदर एंट्रम है, अलाइकर एंट्रम है. एनीवे, सो 25 years of female है, she has amenorrhea only since 4 to 5 months. Very unlikely. बट यहाँ पे एक चीज है कि यहाँ पे उसने एमेनोरिया बोला है. अभी इन्होंने मुझे यहाँ पे से दिया है scanty menses and everything, but whenever there is a mention of amenorrhea at any point, any single point, always you have to say कि sir मैं before doing anything, before doing any evaluation, I'm going to test her UPT. I never know, वो 3 साल से कोशिश कर रही होगी तभी नहीं हुआ, but now she has conceived. So first of all, I want to see if her UPT is negative or positive. अगर पॉजिटिव है तो सब कुछ रूल आउट हो जाता है. इट इज नीदर इनफर्टिलिटी, शी ओनली इज अ प्रेग्नेंट फीमेल, शी हैज टू बी मैनेज्ड अकॉर्डिंगली. बट द प्रॉब्लम बिगिंस इफ शी इज UPT negative and it is amenorrhea. Obviously, it is only since 4 to 5 months, which shows that it is secondary amenorrhea. Secondary amenorrhea and primary amenorrhea में फर्क क्या है? Primary is the amenorrhea, which means that the female never has menstruated. Basically, she is probably 25 years old now, but she has never menstruated. She has never had menarche at all. So since the last 12, 13 years, no bout of menses at all. That is called as primary amenorrhea. Primary amenorrhea women usually do not present so late. They will be very anxious. The family members are going to be very anxious and they'll be brought to your OPD around the age of 15, 16 only as to why aren't they menstruating. Primary amenorrhea as a topic I'm not going to be discussing today. It is going to be for the next session. So yes, there is a question on primary amenorrhea, imperforate hymen, transverse vaginal septum, ये सब पे है, but not today. In the next session, part 3. So secondary amenorrhea है. Secondary amenorrhea, सबसे biggest reason is pregnancy. I have ruled out pregnancy first of all. Then what might be the case? There is one thing that is helping me know the diagnosis, that the menses had gotten scanty prior to that, and she's married since 3 years as well. The most likely diagnosis over here is going to be infertility. Obviously, either uterine factor है या फिर tubal factor है. Of course, it can be a male factor infertility as well. I have to do the entire workup that I mentioned in the last lecture of infertility. But the more likely factors right now seem to be either uterine or tubal. Why do I say uterine? Because scanty menses हो गए थे. Scanty menses मतलब menstruation का जो duration and volume है वो कम हो रहा है. वो कम क्यों होगा? If the endometrium is not proliferating adequately. Because if endometrium ही नहीं बन रहा है अच्छा खासा, वो बहुत thin रह रहा है, then bleeding नहीं होगा. If the endometrium is not forming properly, it can indicate that there is probably some hormonal problem. Hormonal problem मतलब body में estrogen adequate नहीं है, possible है, या फिर there is something in the endometrium that is not letting it grow despite normal hormones. So whenever a female is giving me history of amenorrhea, scanty menses, तो सबसे पहले मैं उसका कौन सा टेस्ट करना चाहूंगा? Hormonal profile. Hormonal profile कौन सा? Last time मैंने जो डिस्कस किया था, TSH, प्रोलैक्टिन, FSH, LH. ये 4 करके मुझे देखने हैं कि उसके कोई पिट्यूटरी के लेवल पे तो प्रॉब्लम नहीं है, एंड TSH, हाइपोथायराइड या हाइपरप्रोलैक्टिन का तो इशू नहीं है. तो सबसे पहले मैं वो देखना चाहूंगा. Once the endocrinological problems are ruled out, then I know that it has something to do with the endometrial anatomy, जिसके वजह से उसको scanty menses हुए हैं. Looking at this picture at the moment, it is very likely 4-5 months से amenorrhea है. I will want to ask कि उसको कोई constitutional symptoms है, and then the examiner says कि yes, she mentions that she has had a little decrease in her appetite, she experiences chronic pelvic pain, she has been losing her weight थोड़ा थोड़ा थोड़ा. All these things points towards only one thing, and that one thing is going to be PID, जो क्रॉनिकली उसको चल रहा है. और क्रॉनिक PID की मैं जब बात करता हूं तो सबसे पहले मेरे मुंह में आता है जेनाइटल ट्यूबरकुलोसिस का डायग्नोसिस. सो Genital tuberculosis, the secondary might be chronic long-standing PIDs like chlamydia, gonorrhea, ये सब भी हो सकते हैं. But all these constitutional symptoms and everything points towards genital tuberculosis. Great. जेनेटल ट्यूबरकुलोसिस है, मुझे अभी तक प्रूव करना है, ठीक है, मैं प्रूव करूंगा, डायग्नोसिस करूंगा. बिफोर दैट आई वुड वांट टू आस्क यू ऑल, द एग्जामिनर आस्क्स मी कि मुझे तुम बताओ कि सेकेंडरी एमेनोरिया क्यों होगा लेकिन इन अ फीमेल हु हैज जेनेटल ट्यूबरकुलोसिस, हाउ डू यू एक्सप्लेन दैट? आई टेल हिम, सर देयर आर टू रीजंस, टू मेजर रीजंस फॉर एमेनोरिया. यहाँ पे कंसेप्ट शुरू होते हैं. सो देयर आर टू रीजंस for amenorrhea in a female with genital tuberculosis. मैं GTB लिखने वाला हूँ, genital tuberculosis. What are the two reasons for amenorrhea? The first reason is going to be in the brain, and the second reason is going to be in my uterus. तो सर बोलते हैं ओके, कुछ तो बना रहे हो कंसेप्ट, ठीक है, क्या कंसेप्ट है, थोड़ा और मुझे बताओ. देन आई टेल हिम दैट सर पहले मैं यूट्रस बताता हूँ कि वो ज्यादा इजी है. जब भी कोई पीआईडी होता है, पीआईडी का बॉडी का रेस्पॉन्स इज गोइंग टू बी, वहां पे अपने एंटीबॉडीज लाओ, ल्यूकोसाइट्स लाओ, उसको डिस्ट्रॉय कर दो. पेशेंट को अगर फीवर या कुछ आया तो पेशेंट आएगा डॉक्टर के पास, द गायनेकोलॉजिस्ट इज गोइंग टू गिव दैट फीमेल अ येलो किट और सम एंटीबायोटिक्स, जिसकी वजह से वो इरेडिकेट हो जाएगा इन्फेक्शन. द प्रॉब्लम इज ये है एक्यूट पीआईडी वाली ऑर्गेनिजम्स, एक्यूट पीआईडी जिनसे हो रहा है उनमें होता है. बट व्हाट अबाउट दोस लॉन्ग स्टैंडिंग क्रॉनिक पीआईडीज, स्पेशली जो माइकोबैक्टीरियम ट्यूबरकुलोसिस में होते हैं? रिमेंबर, ट्यूबरकुलोसिस से होता है chronic inflammation, and chronic inflammation का end outcome is often fibrosis. So यूट्रस के अंदर there is likelihood कि वहां पे एंडोमेट्राइटिस हुआ था, एंडोमेट्राइटिस बहुत क्रॉनिक चला, बहुत लंबे समय तक चला, एंड ये क्रॉनिक एंडोमेट्राइटिस से हुए adhesions, fibrosis, adhesions due to fibrosis. ये फाइब्रोसिस को नाम हमने दिया है एक अच्छा सा, उसको कहते हैं एशरमैन सिंड्रोम. एशरमैन सिंड्रोम इज बेसिकली, ये मेरा यूट्रस है ऐसा, यहाँ पे ट्यूब्स है, ये यूट्रस के अंदर देयर विल बी ऐसे पैचेस जहां पे एंटीरियर एंड पोस्टीरियर वॉल ऐसा चिपक गया होगा, एंटीरियर एंड पोस्टीरियर वुड बी स्टक अप at those locations. Such adhesions are called as Asherman syndrome. This is the initial stage, initial क्या बोलूंगा मैं उसको, आउटकम ऑफ थिंग्स लाइक एंडोमेट्राइटिस, या फिर इफ यू हैव डन अ विगरस curettage after any abortion or for endometrial hyperplasia, बहुत जोर जोर से तुमने किया. Remember there are two layers, there is a basal layer and then the functional layer of endometrium. So if you do बहुत ही जोर से rigidly अगर करोगे तो basal endometrium भी erode हो जाएगा. If you have removed the basal endometrium is the one जो proliferate करता है और endometrium को replenish करता है. If you remove the basal endometrium, then there will be nothing to be replenished and वहां पे होगा fibrosis. तो विगरसली इसलिए हम हमेशा कहते हैं नेवर डू अ क्यूरेटाज. देयर इज अ टर्म दैट वी यूज कि ग्रेटिंग सेंसेशन आने तक हमने क्यूरेटाज किया. दैट इज अ वेरी रॉन्ग थिंग टू डू. नेवर डू endometrial curettage, be it for missed abortion or incomplete abortion, or be it for endometrial hyperplasia, abnormal uterine bleeding. Never do it so harshly कि तुम end का outcome उसको directly Asherman syndrome में दे दो, because Asherman syndrome is also not a great thing to happen. This female will have no endometrium और उसका आगे का इनफर्टिलिटी का जो प्रॉब्लम होगा वो डिफिकल्ट होगा सॉल्व करने के लिए. ओवर अ पीरियड ऑफ टाइम these patches engulf the entire uterus. The entire uterus is engulfed and पूरा यूट्रस चला जाता है. इसको हम कहते हैं इवन वर्स नेटर सिंड्रोम. नेटर सिंड्रोम इज बेसिकली पूरा एंडोमेट्रियम चला जा चुका है. सो नेटर सिंड्रोम इज एन एडवांस स्टेज ऑफ एशरमैन सिंड्रोम. ये मैं बात करते ही जा रहा था तो सर ने मुझे पूछा कि जस्ट वेट फॉर अ मोमेंट, यू आर सेइंग कि क्रॉनिक एंडोमेट्राइटिस हुआ है बिकॉज ऑफ ट्यूबरकुलोसिस, बट हाउ विल ट्यूबरकुलोसिस अफेक्ट योर यूट्रस, योर जेनिटल ऑर्गन्स? डज इट कम फ्रॉम द वजाना, जैसे अपना बैक्टीरियल वजानासिस या फिर पीआईडी गोनोरिया ऐसा बात है वैसे ऊपर आता है? आई टेल हिम नो सर, रिमेंबर कि द माइकोबैक्टीरियम इज समथिंग दैट विल नॉट सर्वाइव इजीली द एसिडिक एनवायरनमेंट ऑफ द वजाना. So it is very unlikely for the tuberculosis or mycobacterium to have come into the uterus ascending route से, मतलब वजाइना से बाहर से आने के चांसेस कम है। तो सर बोलते हैं बराबर बोला, फिर आया कहाँ से? देन आई विल टेल कि जेनेटल ट्यूबरकुलोसिस इज ऑफन अ सेकेंडरी एक्स्ट्रा पल्मोनरी टाइप ऑफ ट्यूबरकुलोसिस एंड द प्राइमरी फोकस, द प्राइमरी लीजन इज ऑफन द lungs. Primary lesion in most of the patients, most of the women is going to be the lungs. काफी बार लंग्स का सब क्लिनिकल इन्फेक्शन आता है या चला जाता है, या फिर एक एक्टिव इन्फेक्शन आता है जिसके लिए फीमेल लेती है एकेटी, दैट इज एंटीकॉक्स थेरेपी. But after a few months or after a few years, because of the dissemination that has happened from the lungs to various other organs, it can be even in the spine, it can be in the gastrointestinal tract, it can be in the genital tract. ये सब जगह जहाँ पे जाता है, the worst that is affected is going to be my genital organs. Genital organs में सर पूछते हैं कि सबसे पहले कौन सा organ affect होता है? I tell him, sir, uterus is the third most likely organ. The first most likely organ is going to be my fallopian tube. तो सर बोलते हैं बेटा, बिफोर गोइंग टू द फैलोपियन ट्यूब, जस्ट कंप्लीट वन क्वेश्चन दैट आई आस्क्ड यू बिफोर. दैट क्वेश्चन इज द कॉज ऑफ एमेनोरिया. तो आई टेल हिम, ओके सर, द कॉज ऑफ एमेनोरिया इन अ फीमेल विद जेनिटल ट्यूबरकुलोसिस वाज ये एंडोमेट्राइटिस की वजह से जो एडिशंस हो गए हैं, एशरमैन सिंड्रोम हो गया है, उसके वजह से द एंडोमेट्रियम इज डिप्लीटेड, द एंडोमेट्रियम इज कंप्लीटली एब्सेंट एट ऑल दीज लोकेशन. सो जो भी थोड़ा बहुत यहाँ आजू बाजू में बैठा हुआ एंडोमेट्रियम है, उसमें से सिर्फ स्कैंटी मेंसेस आएगा. But once the fibrosis becomes बहुत ज्यादा like in Netter syndrome, then there will be complete amenorrhea. There will be amenorrhea first of all because there is an obstruction to the outlet. ये cervical introitus के इधर ही cervical in os के इधर internal os के इधर ही fibrosis हो गया है. So there is going to be a problem in the outlet of menses, as well as all the endometrium has been converted to fibrosis, which is why there is no endometrium left to menstruate. तो पहले scanty menses आएंगे बहुत लोगों को, उसके बाद में amenorrhea आएगा. He tells me perfect. Now what about the brain? I tell him, sir, remember that a female's body is very, very sensitive to any forms of stress, be it lack of sleep, sleep deprivation, be it any exam related or work related stress, जिसके वजह से that person is putting in long hours into studying or working, or anything like a chronic illness in the body, be it some autoimmune disorder, be it some chronic illness like tuberculosis. When this happens in my body, there is a chronic inflammatory state. This inflammatory state affects the secretion of GnRH. GnRH that we had discussed परसों also, which requires a pulsatile release from the hypothalamus so that pituitary से FSH और LH secrete हो सके. ये पल्सेटाइल रिलीज अगर डिस्टर्ब हो गया, ये पल्सेटाइल रिलीज अगर डिस्टर्ब हो गया तो एफएसएच एलएच सीक्रेट नहीं होगा. अगर एफएसएच एलएच सीक्रेट नहीं होगा तो होगा एन ओव्यूलेशन. ओव्यूलेशन ही नहीं होगा. अगर ओव्यूलेशन नहीं हुआ तो ना रहेगा ईस्ट्रोजन, ना रहेगा प्रोजेस्टेरॉन. And if there is no estrogen or no progesterone in the body, then how will a female menstruate? Obviously, वो menstruate तो करेगी ही नहीं. This is what we call as hypothalamic amenorrhea. Basically, hypothalamic amenorrhea is hypothalamus which is leading to amenorrhea. The cause, though, is the chronic stress that has been induced in the body by this inflammation. Now, hypothalamic amenorrhea is not just seen in stress-induced situations, it is also seen in athletes, physical athletes, runners, long-distance runners who are very thin. Their body often has continuous high metabolism, उनके muscles का भी wasting होते रहता है, and because of that in their body there's a high state of inflammation which leads to hypothalamic amenorrhea. One more reason, sir will ask me कि ठीक है ये छोड़ के और कोई reason तुम्हें पता है? I'll say there's one more reason. There's a hypothesis which says that for a female to start menstruating, there should be somewhere between 15 to 20% of fat in her body, and for her to be able to consistently menstruate every month, there has to be around 17 to 20% of fat in her body. In a female who is having TB since a long time and she's losing her weight consistently, if she has become too frail, बहुत ही पतली हो गई है, in that female, her peripheral fat is almost non-existent. This is again creating a state of chronic malnutrition, और malnutrition के stress के वजह से ये female को फिर से hypothalamic amenorrhea हो रहा है. So these are the three reasons: loss of weight, hypothalamic amenorrhea, and uterine fibrosis or endometrial fibrosis due to endometritis that leads to amenorrhea and scanty menses in women. Did everyone understand this concept of amenorrhea in tuberculosis? Does anyone have any doubt? Did everyone know this concept before? Does anyone have any doubt at this point? Am I audible? Yes, sir. Okay. Could you explain the last part again? Last part मतलब कौन सा exactly? Fat requirements. Fat requirements is basically there's a hypothesis. It is not yet evidentially proven. This is a concept that has been given even in Speroff, which is Gynec Endo ka book. It says that a female requires a certain percentage of her body weight in the presence of fat. That percentage is around 17 to 22% के बीच में, 15 to 20 ऐसा इसके बीच में ही कुछ तो है. It is I think 17 and 22. um, that percentage is essential for first of all menarche, and then to have a consistent menstruation every month regularly. So in women who have tuberculosis for a long period of time, who are losing their weight due to loss of appetite and all the chronic inflammatory state in their body, in them, because of that percentage of fat not being there in them, they do not menstruate. So that is the fat requirement ka part. The exact percentages are given in Speroff. I'll let you know after the session on the group. Okay, then proceeding. So coming back to the session, then sir asked me कि okay, now tell me कि तुम बता रहे थे कि सबसे ज्यादा जो अफेक्ट होता है वो तो है फैलोपियन ट्यूब. ये फैलोपियन ट्यूब का भी मुझे थोड़ा बता दो कि क्या क्या होता है फैलोपियन ट्यूब में. आई टेल हिम सर फैलोपियन ट्यूब का सबसे इम्पोर्टेंट जो काम है, सबसे इम्पोर्टेंट जो वर्क है वो है, या फिर उसका सबसे इम्पोर्टेंट क्या बोलूं उसको मैं, फंक्शन है, इज टू मेंटेन द पेटेंसी ऑफ इट्स ओन ट्यूब. सो फैलोपियन ट्यूब का जो ट्यूब होता है उसके अंदर का जो पेटेंसी होता है, दैट इज द मोस्ट इंपॉर्टेंट थिंग और मोस्ट इंपॉर्टेंट पार्ट ऑफ दैट ट्यूब. once that once that patency is lost due to any reason, it can be because of an ectopic pregnancy जिसके लिए रिपेयर हुआ है, या फिर any PID, old PID. Once that patency is lost, it is very difficult to restore that patency. Remember, even if I'm managing to restore that patency, ये जो ट्यूब होती है, ये जो ट्यूब होती है यहाँ पे, ये ट्यूब के अंदर होता है छोटा 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 सीलिया. दिस सीलिया विच इज वेरी इंपॉर्टेंट फॉर ओवम एंड sperm to be able to meet, and then once the embryo is formed, the embryo to come into the uterus. Whenever there is any episode of any pelvic inflammatory disease, acute or chronic, और हिस्ट्री ऑफ एक्टोपिक प्रेगनेंसी कुछ भी अगर पहले हुआ है, या फिर एनी पेल्विक सर्जरी दैट हैज बीन डन जिसमें ट्यूब को कोई तो नुकसान हुआ है, एंड वंस द पेटेंसी इज लॉस्ट, इवन इफ आई एम एबल टू रिस्टोर द पेटेंसी, these cilia, these microtubules or cilia, whatever you call them, they won't be restored, which is why even if I'm restoring the anatomy, fertility is not guaranteed. क्योंकि ये cilia का जो function है वो तो चला एक बार गया, तो वो तो restore नहीं हो रहा है. इसलिए it is very crucial that the patency is maintained, and once it is lost, reopening it is never going to guarantee you that pregnancy is going to occur in that female. Now, whenever this female is getting chronic PID, obviously, जैसे यूट्रस के अंदर हुआ है, even in those tubes, there is going to be, or there are going to be multiple adhesions that keep on occurring. Those adhesions, just like यहाँ पे से patches थे, एशरमैन सिंड्रोम में पहले ऐसे पैचेस बन रहे थे, वैसे ही ये ट्यूब में भी देयर विल बी वेरियस पॉइंट्स जहां पे अलग अलग पॉइंट्स पे ये फाइब्रोसिस होगा इनिशियली. सो बेसिकली हाउ डू आई नो कि ये कहाँ कहाँ पे पैचेस हो रहे हैं? One way is a test called as HSG, हिस्ट्रोसाल्पिंगोग्राम, wherein मैं यहाँ से एक डाई इंजेक्ट करता हूँ. ये डाई सब जगह से जाता है जहां पे देर इज ऐसा फ्री स्पेस टू गो. देखो ऐसा, लेकिन जहां पे भी ऐसा फ्री स्पेस नहीं रहेगा, लाइक दिस एरिया यहाँ पे, वहां पे आई एम नॉट गोइंग टू गेट एनी डाई दैट इज गोइंग। सिमिलरली इन द ट्यूब एज वेल, जहां पे भी जगह है वहीं से वो आगे जाता रहेगा। But after a point of time, because this is a chronic inflammatory state, there are going to be multiple such patches, and those multiple patches are eventually going to consume the entire tube. This entire tube is going to be consumed. ये सब कैसे changes दिखेंगे? I have multiple hysterosalpingography के graphs that are available. I'll be showing you next. Finally, यहाँ पे आता है मेरा फिम्ब्रिया। ये ऐसे फिम्ब्रिया होता है। अब फिम्ब्रिया में इनिशियली ये फाइब्रोसिस जब स्टार्ट होता है, ये सब फिम्ब्रिया ऐसे पास आने लगते हैं, ऐसे पास आने लगते हैं। क्यों? क्योंकि इनके बीच में भी फाइब्रोसिस चालू हो जाता है। दीज स्टार्ट स्टिकिंग टू ईच अदर। नाउ दिस फिम्ब्रिया सर्व्स अ वेरी इंपॉर्टेंट फंक्शन ऑफ कलेक्टिंग द ओवम दैट हैज ओव्यूलेटेड फ्रॉम द ओवरी। ये अगर ओवरी है, इसको पकड़ने का काम ये फिम्ब्रिया का होता है। सो वंस देयर इज फाइब्रोसिस दैट इज स्टार्टिंग टू अकर, this will literally look like this. Basically, all these fimbria are now stuck up इसके अंदर ऐसे fibrosis के वजह से. Their function obviously to pick up the ovum is lost. How will this look on the hysterosalpingograph? I'll show you the pictures. सबसे पहले एक नॉर्मल हम पिक्चर देखेंगे। ये है एक नॉर्मल ट्यूब का पिक्चर या फिर नॉर्मल एचएसजी का पिक्चर। सी दिस और नॉर्मल पिक्चर। यहाँ पे यूट्रस देखो, यहाँ से मैंने डाई डाला, ये व्हाइट कलर का डाई है, इवनली पूरे यूट्रस में गया है। ये डाई पूरी तरह से इवनली गया है। यहाँ पे यू सी दिस ट्यूब, दिस इज द पेटेंसी इनसाइड द ट्यूब। दिस ट्यूब इज कंप्लीटली पेटेंट। ऑल्सो सी दैट दिस ट्यूब इज वेरी कॉन्वोल्यूटेड एंड लॉन्ग, एकदम मस्त कॉन्वोल्यूटेड है, लॉन्ग है, पेटेंसी भी अच्छा खासा है। दिस इज अ नॉर्मल ट्यूब एंड ऑब्वियसली दोनों के फिमरियल एंड से यहाँ पे डाई स्पिल हुआ है। दिस इज अ नॉर्मल हिस्टोसाल्पिंगोग्राम। एबनॉर्मल क्या होता है? एबनॉर्मल में सबसे पहले तो मैंने बात किया था एशरमैन सिंड्रोम। तो एशरमैन सिंड्रोम यू कैन सी ओवर हियर, ये पार्ट पे the dye has not filled up. This is that patch that I was initially talking about. ये इनिशियल पैच यहाँ पे बन चुका है। धीरे धीरे यहाँ पे ऐसे मल्टीपल पैचेस बनने वाले हैं यूट्रस में। फाइनली ये पूरा यूट्रस खा जाएगा, जिसको हम नेटर सिंड्रोम बोलेंगे। बट फॉर नाउ दिस इज एन एग्जांपल ऑफ एशरमैन सिंड्रोम। देन आई मेंशन्ड कि जो ट्यूब है उसमें धीरे धीरे ऐसा पैची ये बनने वाला है, ऐसा पैच जैसे बनने वाले हैं। दिस इज गोइंग टू लुक ऐसे। दिस इज व्हाट वी कॉल एज द बीडेड ट्यूब अपीयरेंस ऑफ ट्यूबरक्यूलोसिस। बीडेड ट्यूब अपीयरेंस। बीडेड ट्यूब, यू सी ऑल दोज व्हाइट गोला जो है उसमें से डाई पास हो रहा है। whereas ये जो एरियाज है, यहाँ पे जो एरियाज है ऐसे वाले, these are the areas जहां पे डाई हो नहीं पा रहा है। these are the areas जहां पे adhesion स्टार्ट हो चुके हैं। whereas ये व्हाइट एरिया है जिसमें से जा पा रहा है अभी एटलीस्ट। सिमिलरली यहाँ पे भी यू कैन सी these are the areas जहां पे डाई नहीं जा पा रहा है। this is the patchy adhesions of the fallopian tube that have occurred. आगे जाके when you come you will see that ये जो फिम्ब्रिया था मैंने बताया था जैसे कि वो एक ऐसा पाउच के अपीयरेंस में आएगा। ऑल दिस फिम्ब्रिया आर स्टक कंप्लीटली। व्हेन दे आर स्टक कंप्लीटली, this gives an appearance of a tobacco pouch. This is a tobacco pouch appearance. Tobacco pouch क्या है? एक ऐसा पोटली होता है। ये पोटली पुराने जमाने में लोग यूज करते थे, इधर ऐसा धागा होता था। इसके अंदर they used to keep tobacco so that the tobacco doesn't get wet with the outer atmospheric humidity. तो इसके अंदर रखते थे। So this looks literally like that पोटली यहाँ पे ऐसे धागा अगर रहता तो। So this is called as a tobacco pouch appearance. This tobacco pouch is basically all the fimbria have accumulated together और dye यहाँ पे आके जमा हो रहा है। It is not spilling outside. There is no spill on this end. This is the tobacco pouch appearance. Eventually, this tobacco appearance pouch जो है, ये जो ट्यूब है जो पहले एटलीस्ट ऐसा था, this will eventually completely fibrose and it will be just like this. बस ऐसा बचेगा। An example is this. पूरा छोटा हो गया अभी एंड दिस इज नाउ लिटरली लुकिंग लाइक अ, स्पेशली यहाँ का देखो, यहाँ का दिस इज लिटरली लुकिंग लाइक अ गोल्फ क्लब। गोल्फ क्लब इज बेसिकली जिससे गोल्फ खेलते हैं वो ऐसा दिखता है क्लब। दिस इज नोन एज द गोल्फ क्लब अपीयरेंस इन ट्यूबरक्यूलोसिस ऑफ द फैलोपियन ट्यूब्स। गोल्फ क्लब अपीयरेंस। There is one more thing that I would want you all to appreciate over here. You see that even though the patency is यहाँ पे patency is still maintained, the convolutions are lost. The length of the tube is reduced. The length जो पहले बहुत ऐसा ऐसा लंबा लंबा होता था ऐसा वो सब कम हो गया है. And now it is very straight and very thin. This straightening loss of convolutions is called as lead pipe appearance. Lead pipe appearance. Basically, no convolutions, एकदम straight. This is a picture that I've taken in my OPD of a female. You can look over here. You can see first of all lead pipe एकदम सीधा ऐसा इसमें से आ रहा है. ज्यादा convolutions नहीं है. यहाँ पे there is the tobacco pouch appearance, very classical. And यहाँ पे you can see there are multiple patches of Asherman syndrome. Multiple patches यहाँ पे. All these patches are of Asherman syndrome. This also female had a septate uterus ऐसे. Septate uterus is something that I'll talk in the next session. But basically और यहाँ पे जो तुम लोग डाय देख रहे हो that is basically यहाँ का डाय वहां पे आ चुका है. But यहाँ पे you find all these classical findings of Asherman syndrome, tobacco pouch appearance, lead pipe, which is basically genital tuberculosis. And that is how you interpret your HSG in a female with genital tuberculosis. Now you would ask me, what are the other ways of knowing? You tell your examiner कि sir HSG is an excellent way of knowing how do we or how to know whether there is tuberculosis or not. But then sir asks you a very important and pertinent question. He asks you कि what if that tuberculosis का bacteria was present in this part, यहाँ पे tuberculosis था. तूने HSG करके उसको disseminate कर दिया into the tubes outside in the peritoneal cavity. Obviously there might पहले से हो सकता है, but theoretically you can disseminate the infection outwards. So is HSG the best modality? I tell sir कि no. There are multiple other modalities of knowing or for diagnosing genital tuberculosis. He tells me what is the easiest modality. The easiest I tell him is whenever this female will menstruate. Now remember that Mycobacterium tuberculosis जो होता है, it's an aerobic bacteria. It literally requires plenty of oxygen. Oxygen tension बहुत ज्यादा लगता है उसको for it to survive. Obviously, if it has to survive inside the uterus, it is going to survive on the superficial most layer. मतलब ये अंदर वाले लेयर पे वो सबसे बाहर वाले लेयर पे रहेगा and not the inner layer of the endometrium. So basically functional endometrium का जो सबसे superficial layer है of endometrium, that is where it has the best chance of living because oxygen जो है उस area में maximum contact है. So whenever a female menstruates, the first ever menstrual blood that she has in every month is going to be the most superficial layer of the endometrium shedding. So we take the first menstrual blood of a cycle and we do something called as PCR. We can also do something called as CBNAT or Gene Expert, anything. But remember, the first menstrual blood is required for that. But the problem is, the female says, ki, "Sir, I understand your point. Ki first menstrual blood is important, hai, but I cannot predict when I'll be getting my first menses. It is often after I get the first bleeding episode is when I know ki now I'm menstruating. So that first blood is often lost in the pads or something, and I'm not able to collect it." Then I tell ki I understand that is absolutely okay. We have other methods also to check whether there is whether there is presence of mycobacterium inside you. I tell her कि I can do your pre-menstrual, मतलब just before she menstruates, curettage. मैं curettage करके तेरा endometrium ले सकता हूँ. And then I can send it again for PCR or CBNAT or Gene Expert. But she tells, the patient asks me, sir, but you had told me कि endometrium तो ठीक है, but what if my endometrium is not infected at all and it is only my tubes that are completely destroyed by tuberculosis? I don't probably have Asherman syndrome. What in that scenario? मेरा ये menstrual blood या फिर endometrium का जो तुम करने वाले हो PCR, all of that is going to be negative. Then what do you do for that? And we have already done HSG. HSG has not shown me enough. Then what is the other best way? Then I tell her the gold standard is always going to be laparoscopic or diagnostic laparoscopy. Diagnostic laparoscopy with chromoperturbation से मुझे अंदर lesions भी दिखेंगे, caseating granulomas भी दिखेंगे, and I'll also be able to collect the peritoneal fluid to test for to test for genital tuberculosis. Now, in this picture, you can see how these caseating granulomas have grown on a laparoscopic picture. You can see all these granulomas that have grown. And you can look at the tube as well. This tube looks very inflamed. यहाँ पे देखो इतना vasculature है उसको with all these caseating granulomas. So basically, this is a picture of genital tuberculosis. You can also see that the length of tube is quite reduced. ये fibrosis जैसा ही हो गया है इसके अंदर. The fibrosis has reduced the length of the tubes. You can also see यहाँ पे कैसे all the fimbria are stuck up. This is very classical finding on laparoscopy that we get for tuberculosis. ये सब जो केशिएटिंग ग्रैनुलोमा है मैं उसमें से एक ग्रैनुलोमा को थोड़ा सा एक्सरसाइज करके भेजूंगा और जीन एक्सपर्ट में फ्लूइड भी जो मिलेगा उसको भी भेजूंगा एस्पिरेट करके एंड देन आई विल अवेट द रिपोर्ट एंड इफ शी इज सेंसिटिव टू रिफैम्पिसिन देन आई विल स्टार्ट ऑन कैटेगरी 1 of AKT, that is rifampicin, isoniazid, the rifampicin, isoniazid, pyrazinamide, and ethambutol. So this is the first category that I'm going to be starting her on. The duration is usually between 6 to 9 months, but it can be extended even till 12 months to 18 months if I'm not getting a negative report for her or if her symptoms are not improving. The next question the patient will ask you, sir, after the therapy, will I be okay? The answer is no. Your tubes, once they have lost the patency, once they have lost the ciliary function, motility function, they cannot be regained. Then she asked me, sir, ये जो tuberculosis का treatment है, it has several side effects. I get a lot of nausea, vomiting. If it is not going to help me anyway, then why should I be taking that medicines? Why should I be taking it? Then I will tell her, remember that whenever these mycobacteria are present inside the tubes or inside your uterus, they are secreting inflammatory cytokines. They are secreting a poisonous fluid, basically cytokines release kar rahe hai, which is toxic to the embryo. So even if your tube has lost the functionality, we can still do IVF, but even that IVF will fail for you because all the inflammatory cytokines, the inflammatory fluid that is secreted by the mycobacteria will kill the embryo that we shall be putting inside you, which is why we need to ensure that all these mycobacteria are killed and then you can start conceiving. She asked me, do I have to wait till the end? I can tell her ki no, even if the intensive phase is over, then you can be assured and you can start conceiving. She tells me category 2 pe bhi chalega? No, category 2 mein there are things like amikacin, kanamycin, all these drugs are teratogenic, so you would have to wait till the end of the treatment. If you're taking category 1, that is all the HRZD wala drugs, then you can conceive. So that is it about genital tuberculosis. Does anyone have any doubt up to this point? Has everyone understood this? Ovary. Next is ovary. So chromoperturbation will not spread infection. Yes, it will spread, but it is only to check कि if there is any tubal blockage है या नहीं है. But अगर मैं कर रहा हूँ laparoscopy, ऊपर से भी मेरे को अगर एक caseating granulomas दिख गया, so I will not possibly कर मुझे दिख ही गया है, so I would know कि already it has spread till the tubes, so अभी क्या ही disseminate होगा. At least मैं chromoperturbate करके ये तो जान लूँ कि उसका tube में patency है भी या नहीं. So if I'm seeing granulomas anyway, then it has anyway disseminated into the abdomen. So should we get on to the next question for tonight? Did everyone understand this discussion and how do the changes occur on HSG? We have often studied all these HSGs in the exams. We have studied the names of all these changes, but we often don't know कि ये changes कैसे आते हैं. So should we move on to the next question? Okay, then I am getting ahead to the next question. I hope everyone understood this discussion, everyone understood this topic. So the next question I'm coming to the most important discussion, the most important question, and that is going to be on pelvic organ prolapse. Now, pelvic organ prolapse is going to take a long time, so I will start with that. So, a very important discussion now. Pelvic organ prolapse is the third time that I'm going to be discussing pelvic organ prolapse, and it will be the last time that I'm discussing it. So, please, whoever has not paid attention in the previous couple of sessions, please do right now. So, I have a female who has come to me. The second question, a female who has come to me, and that female, she's a 30-year-old nulli gravida, and she has come to me with complaints of something coming out per vaginum. She says that she's a nulli gravid. She's just married since 1 year, and now she has started trying to conceive. But there's something that is coming out from her vagina is making it difficult for her to even have a good coitus or have a good sexual life. So what do I do for this female? A very simple question. काफी बार तुम्हें findings भी दे रहेंगे per speculum या per vaginal. अभी मैं सिर्फ एक लाइन के ऊपर पूरा pelvic organ prolapse का डिस्कशन करूंगा. Now, whenever I talk of pelvic organ prolapse, I can have two age groups. It can either be a young female who wants fertility, or it can be an old female who doesn't want fertility and she's done with her childbearing. Two major classes. फिलहाल के लिए इतना बस याद रखो. Before going to this topic again, I will be first talking about all the concepts of pelvic organ prolapse. So, just giving you an overview of how the pelvis looks to me as an obstetrician or as a gynecologist, it is a little different from how you see it as an undergraduate or a postgraduate student who has not probably done too many surgeries. So, how do I see it? This is the lateral or the sagittal view that I'm going to be showing you. So, laterally, this is my sacrum. So, obviously, this becomes my posterior end. This is my pubic symphysis and obviously the anterior end. So, देख रहे हो तुम लोग मैं lateral view बता रहा हूँ. यहाँ पे I have my uterus. इसके आगे है मेरे पास bladder with the urethra and पीछे है मेरा rectum with the anal opening. These are the three organs that are present. Now inside the pelvis, it is like I have three balls that I have kept inside a dabba को और क्या बोलो tiffin box or something, and I'm shaking them. If I shake them or if I just walk with them, these three balls are going to keep impeding. They are going to keep colliding with each other. Imagine ये balls ना होके it is something like very perishable item like a mango that I'm keeping in one dabba and I'm walking vigorously. सुबह शाम उठ रहा हूँ, बंद कर रहा हूँ, सब कुछ कर रहा हूँ. These mangoes are going to get spoiled because they are crashing, they are colliding against each other. Very similarly, my pelvis contains these three essential structures that could have been freely floating in the pelvis if not for something called as the endopelvic connective tissue. सो भगवान ने क्या किया, ऊपर वाले ने बोला कि मैं तेरे को एक गिफ्ट देता हूं. ये गिफ्ट का नाम है एंडोपेल्विक कनेक्टिव टिश्यू. दिस एंडोपेल्विक कनेक्टिव टिश्यू इज लिटरली लाइक cotton that is literally packing these three organs and it is preventing the movement of these organs. It literally densely packs it so that they don't keep on moving nor do they come in touch with each other हद से ज्यादा. लिटरली कॉटन है जो इसको पकड़े रखता है पेल्विस के अंदर. टू गिव इट इवन लिटिल मोर सपोर्ट, there is a ligament which is nothing but the thickening or condensation as we call it of this endopelvic connective tissue which comes पीछे से from the sacrum towards the uterus and cervix. We call this uterosacral cardinal ligament complex. A very important structure. Yeah, nothing but it is literally the condensation or thickening of this endopelvic connective tissue. So basically cotton ही है, but ये cotton को और ज्यादा thick कर दिया है ये location पे, so that it can hold it पीछे. Now what you have learned is there are three levels or three tiers of support. डी लांसी का भी क्लासिफिकेशन है तीन layers का. The uppermost layer is made by the uterosacral cardinal ligament complex. The middle layer is made by this endopelvic connective tissue. ये जो है एंडोपेल्विक कनेक्टिव टिश्यू या फिर कनेक्टिव फेशिया भी बोलते हैं, एंडोपेल्विक कनेक्टिव टिश्यू या फिर कनेक्टिव फेशिया भी बोलते हैं, एंडोपेल्विक फेशिया. The level 2 is this, and the level 3 is the perineal muscles, which includes the levator ani. Remember, levator ani does not exclusively support the third level. It is giving support to all the three layers. But those are all complex concepts that you don't need to know at this stage. At this stage, all you need to know कि ये endopelvic connective tissue है जो सब organs को दूर दूर रखता है. ये दूर जो रखता है इसमें कुछ और भी स्ट्रक्चर्स है. एक स्ट्रक्चर आता है मेरा यहां से पेरिटोनियम. एक पेरिटोनियम जो इसके ऊपर ऐसे जाके निकल जाता है. दिस इज कॉल्ड एज, जो नीचे जा रहा है, पाउच ऑफ डगलस. और इस पाउच ऑफ डगलस में रहता है मेरा इंटेस्टिनल लूप्स. मेरा इंटेस्टिनल लूप्स भी इधर रहता है, स्मॉल इंटेस्टाइन का. सिमिलरली there is a name to all this endopelvic connective tissue between the different layers. This between the bladder and the uterus is called as the paracervical fascia, whereas this between the vagina and the rectum is called as the Denon-Villiers fascia. This which is separating the vagina from the rectum, ये सिर्फ इतना वाला part, इतना part is known as the Denon-Villiers fascia, whereas this is known as the paracervical fascia. This plus this is known as the pubocervical fascia. ये नाम फिर भी इंपॉर्टेंट रखने नहीं है, नाम याद मत रखो, सिर्फ Denon-Villiers fascia तुम्हें याद रखना है. Now there is something very specific about this endopelvic connective tissue. This endopelvic connective tissue is made up of collagen, various types of collagen that are packed in tightly. Also, this endopelvic connective tissue contains a lot of estrogen fibers. Estrogen receptors. ये जो estrogen के receptors होते हैं, there are plenty that are present inside this endopelvic connective tissue. So whenever there are two states, first of all, whenever there is a reduction in the estrogen levels in the body, or if the female has any connective tissue या फिर collagen disorder, या फिर there is excessive stress that has been induced on this connective tissue, endopelvic connective tissue, ये तीनों के वजह से ये फेशिया हो जाएगा वीक. एंडोपेल्विक कनेक्टिव टिश्यू. सो ये जब वीक होगा वो कैसे दिखेगा? This is how it will look when it is weakened, and obviously when this is weakened, all these organs will start moving आगे पीछे, and when they start moving आगे पीछे, the bladder, if it moves too behind or if the rectum comes too ahead, this will lead to weakening of this vaginal wall. Now, why should this problem occur? This problem occurs, estrogen कम कब होगा? Estrogen will be reduced whenever a female undergoes menopause. Basically, whenever there is estrogen deficit in our body, when it comes to menopause, is when these estrogen receptors are going to be devoid of any estrogen. कोलाजन डिसऑर्डर अगर उसको है, फॉर एग्जाम्पल मार्फन्स डिजीज, और फिर मार्फन सिंड्रोम और एलर डैनलॉस सिंड्रोम, ऑल दीज कोलाजन डिसऑर्डर्स, या फिर स्ट्रेस ऑन द टिश्यू. स्ट्रेस कैसे? मल्टीपल वजाइनल डिलीवरीज. Multiple vaginal deliveries में the huge uterus, gravid uterus exerts a lot of pressure on this cotton, this endopelvic connective tissue, which leads to thinning of this endopelvic connective fascia. The more they go into labor, उसका vagina भी stretch होगा because of the head and the body of the fetus. That will lead to all this tissue, this endopelvic connective tissue, to get thinned out. So these are the risk factors for the thinning of endopelvic connective tissue. And the moment it starts getting thinned out, all these organs will start moving freely inside the pelvis. Once it starts moving freely inside the pelvis, all the problems of pelvic organ prolapse will start occurring. What are those problems? The first problem is going to be, I will just show you how a vagina will look like now. Now assume करो ये मेरा vaginal vault है यहाँ पे, इसके ऊपर एक यूट्रस है जो मैं अभी फिलहाल के लिए बाजू में रख रहा हूँ. यहाँ पे anteriorly I have my bladder, posteriorly I have my rectum, ऊपर है मेरा यूट्रस. सो आई कैन ईदर हैव एन एंटीरियर कंपार्टमेंट का प्रॉब्लम, एंटीरियर कंपार्टमेंट मतलब ब्लैडर, या फिर पोस्टीरियर कंपार्टमेंट का प्रॉब्लम, या फिर अपाइकल कंपार्टमेंट का प्रॉब्लम. अपाइकल इज बेसिकली द यूट्रस. So either the uterus can come down because the endopelvic connective tissue is thinned out, the uterosacral ligaments are damaged, या फिर the rectum can come into the vagina because इनके दोनों के बीच का जो डेनोमिलियस फेशिया था वो कम हो गया है, या फिर ये पैरासर्वाइकल या फिर प्यूबोसर्वाइकल फेशिया कम होने की वजह से द ब्लैडर कैन स्टार्ट कमिंग इनसाइड द एंटीरियर वजाइनल वॉल. सो व्हाट आर द वेरियस प्रॉब्लम्स दैट कैन अकर? पोस्टीरियर कंपार्टमेंट वीकनिंग से आएगा रेक्टोसील, एंटीरियर कंपार्टमेंट वीकनिंग से आएगा सिस्टोसील, ओकेजनली इवन यूरेथ्रोसील आएगा बट दैट इज नॉट मच कॉमन. सो सिस्टोसील प्लस यूरेथ्रोसील. एंड अपाइकल से आएगा यूट्राइन प्रोलैप्स. ऊपर लिखता हूं इसको, बेसिकली यूट्रस पूरा नीचे आ जाएगा. देयर इज वन थिंग दो दैट आई हैव नॉट रिटन ओवर हियर, एंटेरोसील. लोगों को लगता है एंटेरो मतलब बॉवेल, बॉवेल है तो पोस्टीरियरली ही आएगा. गलत है ये बात. गलत क्यों है? क्योंकि एंटेरोसील इज गोइंग टू एंटर फ्रॉम द एपेक्स थ्रू दिस पाउच ऑफ डगलस. ये पाउच ऑफ डगलस से नीचे आने वाला है मेरा enterocoel. So enterocoel is actually when there is a defect in the apical structures. So enterocoel is when there is a defect in the apical structures and not in the posterior compartment. Remember this. Why do I say this? Because the repair that we do for rectocoel is not going to treat enterocoel. हम लोग rectocoel के लिए करते हैं something called as posterior colporrhaphy जो मैं आगे पढ़ाने वाला हूँ, but that is not going to work to correct enterocoel because enterocoel को लगेगा apical repair. Anyway, so these are the major things that can happen. Apical में obviously if there is no uterus, the female has already had hysterectomy and it is only the vaginal vault, then only the vaginal vault also can come down, which we call as the vault prolapse. Not common, but it can happen. So now we have a few disorders. First is the rectocoel, then we have the cystocoel, and then we have the uterine prolapse, enterocoel, and vault prolapse. These are occurring because of three compartment का failures: apical, posterior, and anterior. And pelvic organ prolapse and its repair is all based on just these three components. इन तीन components के repair पे ही पूरा pelvic organ prolapse का surgeries are present. Does anyone have any doubts in this explanation of pelvic anatomy, pelvic organ prolapse का anatomy? Does anyone have any doubt? Did everyone understand this concept? Vault prolapse is basically when the uterus has already been removed and there is only the vaginal vault or the vagina that is left behind. The female has already had hysterectomy 10-15 years ago. and now because of the weakening, further weakening, because 10-15 years में the female has further progressed into menopause, the estrogen receptors have depleted further, and the endopelvic connective tissue has become thinner over the last 10-15 years. That has led to now the vault to come down, only the vault. अभी यूट्रस तो है नहीं, तो सिर्फ वजाना है, तो वो वजाना जब बाहर आता है, we call it vaginal vault prolapse. Okay, then I'll proceed. ठीक है. Now coming back to the initial point that I made about pelvic organ prolapse, it can occur in a female. Pelvic organ prolapse can occur in a female who is young and who wants fertility and her uterus intact, and an elderly female who doesn't want any fertility, and hence we can remove a uterus. तो सबसे पहले मैं young female की बात करूंगा because that is what our question says. So in a young female, the female has come to me with a complaint of something coming out per vaginum. 30-year-old female है. We can have two possible scenarios that can happen with her. The first scenario is the very obvious कि इसका पूरा uterus with the cervix has come down. यहाँ ऐसे, एंड यहाँ पे ऐसा वजाना है पूरा ऊपर, बेसिकली ये इसका वजाना है इसका ऊपर. सो बेसिकली द एंटायर यूट्रस हैज कम डाउन, whereas the other possibility is the uterus is in its location, but it is her cervix that has gotten elongated and has come down. ये है इसका वजाना ऊपर. These are the two possibilities that can happen. One wherein the entire uterus has come down, whereas the other one where only the cervix has come down. This is what we call as cervical elongation. ये क्यों होता है मैं एक्सप्लेन करूंगा. ध्यान दे दो, एक्सप्लेन करने वाला हूं cervical elongation which you will not find in any of the books. सबसे पहला इजी वाला मैं बात करता हूं कि यूट्रस क्यों नीचे आएगा. यूट्रस को मैंने बोला था देयर आर टू लिगामेंट्स. These two ligaments, or rather a complex ligament, that is the uterosacral cardinal ligament complex. Now due to multiple vaginal deliveries, remember by the way, ये जो uterosacral cardinal ligament complex है ना, उसके दो halves होते हैं, एक upper half और एक lower half. अपर हाफ एंड लोअर हाफ दोनों मिला के, इट्स नॉट ऐसा डेफिनेट डिमार्केशन नहीं होता, इट्स एन आर्बिट्ररी, इट्स नॉट आर्बिट्ररी, इट्स बेसिकली एन इमेजिनरी डिवीजन बिटवीन अपर एंड लोअर हाफ. द अपर हाफ इज कनेक्टेड टू द यूट्रस, द लोअर इज कनेक्टेड टू द सर्विक्स. सो द अपर एंड लोअर दोनों वीक होने वाले हैं व्हेनेवर अ फीमेल हैज हैड मल्टीपल वजाइनल डिलीवरीज. बार बार ये स्ट्रेच हो रहे हैं ड्यूरिंग प्रेगनेंसी, व्हेन द यूट्रस का साइज इंक्रीजेस, व्हेन शी गोज इन लेबर, व्हेन द बेबी इज कमिंग डाउन, एंगेज होके नीचे आ रहा है, मल्टीपल टाइम्स वो नीचे आ रहा है, उसमें दिस लिगामेंट गेट स्ट्रेच्ड, रिलीव होता है आफ्टर डिलीवरी, वापस अगले प्रेगनेंसी में स्ट्रेच होता है. दिस कंटिन्यूअस थिंग कीप्स ऑन हैपनिंग ड्यू टू मल्टीपल वजाइनल डिलीवरीज. So these women, 30-year-old अगर तेरे पास एक आई है, 30-35-year-old with the entire uterus coming down, she will give you classical history of previous 2 or 3 vaginal deliveries. उसमें से एक या दो घर पे हुए थे, और maybe some दाई conducted it, some midwife conducted it. Basically a female or an attendant who was untrained, who was not an obstetrician, जिन्होंने घर पे conduct किया delivery and they did not understand all the basics of uterus. Prolonged labor हुआ था female को, she was in labor for 24 hours, 36 hours, 48 hours, she had not delivered for a long time. All these histories are classically present. Prolonged labor, multiple vaginal deliveries, non progress of labor, बच्चा अटका था अंदर, बच्चा शायद मर गया पेट के अंदर. All these things are very classically found in histories of young women who have come with complete uterine descent. In comparison to that, ये cervical elongation क्या होता है. Now cervix का anatomy का थोड़ा बात करते हैं. ये जो cervix होता है यूजुअल नॉर्मल साइज का, ऐसा ये cervix मानो, ये सर्विक्स है, दोनों साइड के लिप्स है ये. दिस सर्विक्स contains two things. एक है smooth muscles and the second one is collagen. Plenty of collagen. मेटालोमेट्रिक्स प्रोटीनेज भी होता है ये दोनों के बीच में, बट बेसिकली दीज आर द टू मेजर कंपोनेंट्स, स्मूथ मसल एंड कोलाजन. इनका फायदा क्या है? द स्मूथ मसल हेल्प्स इन द डायलेटेशन ड्यूरिंग लेबर. सो बेसिकली 1 सेंटीमीटर, 2 सेंटीमीटर, 3 सेंटीमीटर से 10 सेंटीमीटर तक जो डायलेशन होता है, इतने से सर्वाइकल ऑस से जब इतना बड़ा बन जाता है वो, ये डायलेटेशन होता है बिकॉज ऑफ दी स्मूथ मसल फाइबर्स. वेयर जो कोलेजन होता है, इससे इफेसमेंट या फिर कितना सॉफ्ट हो रहा है सर्विक्स, वो डिपेंड करता है. सो कोलेजन लिक्विफाई होते जाता है एज लेबर प्रोग्रेसेस एंड इट कीप्स ऑन गेटिंग सॉफ्टर एंड इफेसमेंट इंक्रीजेस. So basically, smooth muscle and collagen both are very essential for the maintenance of cervix and to achieve a proper normal delivery, vaginal delivery during labor. Now, what will happen is this collagen, if there is any defect in this collagen because of something like Marfan syndrome or Ehlers-Danlos syndrome or any other collagen defect, इसके वजह से ये कोलाजन के बीच में जो इंटरलॉकिंग होता है, इंटरलॉकिंग जो होता है जिसकी वजह से ये टेंस रहता है, जिसकी वजह से देयर इज अ हार्डन्ड फील टू द कोलाजन, दिस इज गोइंग टू बी लॉस्ट. So basically, it is going to be defective collagen. Defective collagen है, there is no interlocking, there is no linking of the fibers, जिसके वजह से ये जो यूट्रस है ये बार बार ऐसे नीचे आते रहेगा. This cervix is going to get stretched out by itself. Basically, बहुत ही weak हो जाएगा cervix. Classically, cervical elongation is often seen in these women who have all these connective tissue disorders. The other possibility is, I had just mentioned that the uterus and the cervix, it has uterocervical cardinal ligament complex. There is an upper half and there is a lower half. During labor, when the head is in the cervix, यहाँ पे, if this head is stuck here for a long time due to non-progress of labor or second stage में अटक गया है, which we call as second stage arrest, all these things are going to put a lot of stress on this lower half of uterosacral ligaments, and this lower half is going to get weakened. So whenever this lower half is getting weakened, ये जो upper half है ये फिर भी अच्छा है, इसको कुछ नहीं होगा. This upper half is the one that is supplying the uterus and is keeping the uterus intact in its place. So the uterus will not move, but unfortunately after the delivery is done and when the female is in a recovery period, because this lower half of fibers, uterosacral cardinal ligament fibers, were getting weakened, this will lead to elongation of the cervix. This is very classically again seen in women who give history of even one vaginal delivery, but that one delivery was conducted घर पे by some midwife, by some दाई, बहुत prolonged labor था, finally उसको hospital लेके गए क्योंकि बच्चा नीचे नहीं आ रहा था, या फिर she was in labor pain for a long time in a hospital itself, or maybe the cesarean section was done in the second stage. All these classical histories are indicative of the lower half of fibers getting damaged. Obviously, even the entire ऊपर और नीचे का fiber destroy हो सकता है if all this happened in the latent labor or active labor, but it is more likely to happen if the non-progress or second stage arrest is occurring and the lower half of fibers are going to get weakened. This weakening is going to lead to the cervical elongation. Does anyone have any doubt with how does cervical elongation occur? Did everyone understand this point? Does anyone have any doubt at this point? So can you repeat collagen? Of course not, Anindita, yaar, please, if I'm going to repeat it at this stage, it is already 12 o'clock. I can't be progressing. I'll please reply this to you on your chat. Does anyone have any major doubts? I have to finish this session. Can you repeat collagen? I can't be repeating collagen. That's a huge concept in itself that I just discussed. Has everyone understood this concept until now so that I can proceed? कि cervical elongation क्यों हो रहा है? Jyoti, that's a great question. In connective tissue disorders, both the halves will be affected. That will lead to elongation. But remember that uterosacral ligament जो है, uterus is having a lot more fibers to support it. It also has the round ligament and all the other structures that are supporting it and keeping it in the pelvis, which is why the cervix, which is the least supported structure, is which is what suffers the most when it comes to pelvic organ prolapse or when it comes to cervical elongation, because of the lack of support apart from the lower half of uterosacral ligaments. The uterus has several other supports as well inside the pelvis, which will prevent the complete descent of even the uterus when it comes to Marfan syndrome or Ehlers-Danlos. The cervix only has the lower half of the uterosacral ligaments and a little bit of endopelvic connective tissue, जिसकी वजह से सिर्फ cervical elongation होगा. Fine. So I have not two patients who I can be treating in a young female. The first is the one जिसका पूरी तरह से यूट्रस नीचे है, and the second one is जिसमें cervical elongation हुआ है. The normal cervical length is around CX is cervix. Cervical length is around 1 to 1.5 inches, which is approximately equal to 2.5 to 3.5 centimeters, approximately. So this is a normal length. We call that there is significant cervical elongation when this 1 to 1.5 inches is more than 4 to 5 inches or even more than that. This is said to be significant cervical elongation. So which is the surgery that we do for this? The surgery that we do for this is obviously इतना बड़ा cervix हो गया है, ये cervix को मुझे बस काटना है अभी. We do something called as cervical amputation surgery. Amputation is basically cutting it and re-achieving the original length. So अगर 4 inches था तो उसको मुझे वापस 2 inches या 1.5 inches करना है. This is called as cervical amputation. The other name for this surgery is Manchester Fothergill repair. कुछ बुक्स में इसको मैनचेस्टर गिलियम रिपेयर भी दिया है. इट इज सिमिलर. मैनचेस्टर फॉदरगिल रिपेयर इज द रिपेयर दैट वी डू फॉर सर्वाइकल एम्प्यूटेशन. इसमें हम लोग कुछ नहीं, बस ये सर्विक्स जो इतना लंबा था, इस सर्विक्स को आधा काट देते हैं. नाउ द प्रॉब्लम विद दिस, आधा या फिर आधे से ज्यादा, जस्ट सो दैट वी एंश्योर कि ये जो 4 या 5 इंच का था इसको मैं कर दूंगा 1 to 2 इंच का. Now the problem with this is that all the collagen and smooth muscles were equally distributed throughout the cervix. When I'm amputing, let us assume 50% of the cervix. So 50% of the smooth muscles and collagen is going to be lost. Now I had mentioned that collagen and smooth muscles are very crucial for vaginal delivery, which is why one of the biggest complications of Manchester Fothergill repair was cervical dystocia. Dystocia यानी dysfunctional labor. Basically, the cervix would not dilate during labor and the baby would be stuck up once the female conceives after this surgery was done in her. This will lead to an increased possibility or the increased chances of cesarean section. So India के एक scientist ने named Shirodkar said that I will give you a modification or I will give you a surgery that will prevent this. He said that rather than amputing the cervix, what I'll do is, ये मेरा cervical elongation था. He said rather than amputing the cervix and causing cervical dystocia, हम ऐसे करते हैं कि ये जो यूट्रोसेक्रल फाइबर्स या फिर यूट्रोसेक्रल लिगामेंट आ रहा था, इसको मैं कट करूंगा. आई विल कट दिस ऑफ एंड इंस्टेड मैं इसको कट करके थोड़ा ऊपर के लेवल पे एंटीरियरली लगा दूंगा. बेसिकली जो नीचे हुआ करता था इसको हमने एडवांस किया है ऊपर. ये जब ऊपर एडवांस हो गया और हमने एंटीरियरली इसको बांध दिया, इससे क्या हुआ, ये सपोर्ट को हमने थोड़ा ऊपर कर दिया है एंड द सर्विक्स गॉट स्लाइटली पुश्ड अपवर्ड्स. दिस वाज कॉल्ड एज द यूट्रोसेक्रल एडवांसमेंट. यू वुड आस्क मी कि एंटीरियर का क्या सिग्निफिकेंस है. अगर लैटरली तुम यूट्रस को देखोगे, the uterus is in a antiverted state. So if the uterosacral ligaments are ligated anteriorly यहाँ पे से, then it will ensure कि ये एंटीवर्टेड ही रहे. अगर पोस्टीरियरली करोगे तो प्रॉब्लम हो सकता है. इसको एंटीरियरली करना ये इसलिए जरूरी है सो दैट द एंटीवर्जन इज एंश्योर्ड, बिकॉज अगर रेट्रोवर्ट हो गया तो देयर इज एन इंक्रीज चांस ऑफ इनफर्टिलिटी प्लस इंक्रीज चांस ऑफ रेक्टोसील. कैसे मैं वो बाद में बताऊंगा. बट This was the significance of the modification. But the problem was इससे सिर्फ थोड़ा ही 1 इंच से ऊपर होता था. If the elongation is something like 6 inches or 7 inches, it was not getting reduced adequately. So what we do now is Manchester Fothergill repair plus modification of Shirodkar, which we call as the modified Manchester Fothergill repair. So हम ये दोनों को combine करते हैं. So we cut the cervix जितना 50% नहीं 30-40% 20-30% काटते हैं, and we also advance the uterosacral ligament slightly upwards. So Manchester Fothergill repair plus modification is what we do nowadays, so that not much of the cervix is removed, even cervical dystocia won't occur, and the cervix is pulled upwards. This is called as the modified Manchester Fothergill repair या फिर Shirodkar's modification of Manchester Fothergill repair. Very simple. It is just cervical amputation, nothing more than that. ये हो गया cervical elongation के लिए. What about women who have an entire uterus that has come down because the entire uterosacral ligament has gotten weakened? In them, we have to reinforce the uterosacral ligaments. How do we reinforce them? We have to reinforce them by using an artificial non-absorbable material, suture material called as Mercilin tape. ये Mercilin tape जो होता है, it's a non-absorbable tape which will reinforce the uterosacral ligaments. There are multiple sling surgeries that you can remember. मैं तुम लोगों को एक easy way बताऊंगा. So sling surgeries are divided into 3 classes. They are divided into first of all mobility से. Mobility में it can either be mobile जिसको मैं कहूंगा dynamic sling, or it will be immobile जिसको मैं बोलूंगा static sling. Secondly, it can be either anterior positioned or posterior. And last, it can either be in the form of a closed loop or an open loop. इसका क्या मीनिंग है मैं सब बता रहा हूं. It can either be a closed loop or an open loop. So the first sling surgery that was designed by Purandare, what we call as Purandare's cervicopexy. Purandare sling or Purandare's cervicopexy. Now imagine that you're seeing this female ऊपर से. This is the pubic symphysis. This is her sacrum यहाँ पे. Obviously this is the anterior part. This is the posterior part. ऊपर से देख रहा हूं तो यहाँ पे लेफ्ट साइड है और यहाँ पे राइट साइड है. यहाँ पे बीच में आई हैव माय यूट्रस. ना पुरंदर सेड कि मैं ऐसा करूंगा कि मैं ये यूट्रस जो नीचे गया है एट द लेवल ऑफ द यूट्राइन सर्विक्स, यहाँ पे ये एरिया में सर्विक्स एंड इस्थमस के एरिया में मैं एक टेप लगाऊंगा, ऐसे टेप लगाऊंगा और उसको एंटीरियरली खींचूंगा. एंटीरियरली खींच के मैं यहाँ पे लाऊंगा and I will attach it to a structure called as the rectus sheath. यहाँ पे rectus sheath which is present in front of the rectus muscle, यहाँ पे दो उसके पीछे के rectus muscle रहेंगे, तो ये rectus sheath को मैं attach करूंगा. So this became first of all an anterior sling, plus it was a closed loop, so it was closed. And because rectus sheath is a mobile organ, it is not like bone. It is tough, but it is not like bone. It is not static. If a person is going to cough, the rectus sheath gets pulled out. So it was a dynamic sling. This was the first sling surgery that was done, but this had a few side effects, a few complications. The first one was whenever I would tie this uterus would get pulled anteriorly, and that would lead to retroversion of the uterus. इससे रेट्रोवर्जन हो रहा था. बेसिकली द यूट्रस वाज गेटिंग पुल्ड पोस्टीरियरली एज द स्लिंग वाज पुलिंग द सर्विक्स एंड द isthmus anteriorly. This would lead to tears in the denonvillous fascia. Whenever there are tears in the denonvillous fascia, यहाँ से posteriorly जो rectum था वो आएगा, and this was increasing the chances of rectocele. Also, because of retroversion that was happening, this was increasing infertility. So now we are doing this surgery for a 30-year-old nully gravid female, or probably who still intends to have more kids. I cannot be giving her as a side effect infertility. तो अब क्या करें, इनफर्टिलिटी नहीं होना है तो क्या करें, रेट्रोवर्ट हो रहा है, रेक्टोसील हो रहा है. सो Dr. Praveen Mhatre suggested, one of the legendary surgeons in Vadia, he suggested two changes. There was also one more problem. Whenever we would do a cesarean section, now remember, the isthmus of the uterus is what eventually becomes the lower segment. And we always do lower segment cesarean section. So whenever we would do the cesarean section, this tape would get broken. ये फट जाता था. And after delivery, there would be a recurrence of the prolapse. Because ये anterior sling था, anteriorly आ रहा था, this sling would get broken during cesarean section. So because of these three problems, there were a few modifications that were suggested. The first modification was retroversion correct करने के लिए there is an organ on the, or there is a ligament on the uterus called as the round ligament. Round ligament को they said that we will take a figure of 8 suture यहाँ पे and we will reduce the length of the round ligament. When we reduce the length of the round ligament gets pulled anteriorly, and hence the uterus ka fundus will also get pulled anteriorly, and again the antiversion will be restored. क्यों? क्योंकि मैंने उसका जो राउंड लिगामेंट था उसका लेंथ छोटा कर दिया. This was called as the round ligament plication. Basically, I pulled the uterus anteriorly by reducing the length of the round ligament. This prevented the retroversion. Secondly, लोगों ने बोला कि इसको unnecessarily anteriorly लगाने से अच्छा है इसको posteriorly uterus के बांध दो. This would even prevent cesarean section में the breakage that was occurring. So this also prevented recurrence of the prolapse after LSES that was done for delivery, which is why these modifications were now known as modified Purandare cervicopexy, which is what we do now. So the modifications are we attach it posteriorly, and secondly we also do round ligament plication along with Purandare's sling surgery. Did everyone understand this? Does anyone have any doubt? What is cervical dystocia? Cervical dystocia is basically dysfunctional labor because of the cervix. So because the cervix is not dilating, the baby is not coming down, descent nahi ho raha hai, and hence basically the labor is not progressing. So whenever there is labor dystocia because of the cervix, we call it cervical dystocia. The cervix is not dilating basically. ठीक है. Now because this surgery had so many problems, Dr. Shirodkar said that let me design my own sling surgery. So he said that Shirodkar's sling surgery will have a few modifications. He said मेरे में भी pubic symphysis है, मेरे में भी sacrum है. I have my uterus over here. He said instead of going anteriorly and causing all these problems, I will directly take my tape posteriorly and attach it to the anterior longitudinal ligament on the sacrum. Now, this was, of course, a posterior sling. It was again a closed loop, but because it was attached to a bone and not a rectus sheath like muscle, rectus sheath like structure, it was a static sling. Static यानी ये हिल नहीं पाता था कुछ भी करो. But there were a few problems. The few problems were यहाँ पे there were two muscles that were occurring. एक था psoas major. There were two structures. एक था दोनों साइड पे psoas major जिसमें से जाना पड़ रहा था. And secondly, there was my sigmoid colon यहाँ पे and sigmoid mesentery जिसके मुझे posteriorly जाना पड़ता था. Also, there were the ureters that were present यहाँ पे जिनको injury हो सकता था. Which is why Shirodkar's surgery, despite being a good surgery, posterior surgery है, retroversion नहीं होता है, antiversion is still maintained. It's a static sling which does not become loose with cuffing, straining, and all. This is not preferred by gynecologists because they fear injuring the rectus. They fear injuring the psoas major muscle, the sigmoid colon and the sigmoid mesentery, and the ureters over here. This is why Shirodkar's sling surgery, despite being a good surgery, is not preferred by people. This led to Dr. Virkud saying कि I will combine Purandare and Shirodkar and make my own surgery. By the way, a way to remember this is in Marathi, we call Purandare and Pudhe. Pudhe is basically in the front and Purandare also starts from Pu. So Pudhe Purandare. So basically anteriorly is Purandare, whereas S stands for Shirodkar and S also stands for sacrum. So that is one way of remembering it. Virkud said that I will make a composite sling. So in composite sling, he said कि मैं पुरंदरे और शिरोडकर दोनों को कंबाइन करूंगा और उनके डिसएडवांटेजेस निकाल दूंगा. सो यहाँ पे था प्यूबिक सिम्फाइसिस, यहाँ पे था सेक्रम, यहाँ पे था मेरा यूट्रस. ही सेड दैट द प्रॉब्लम वाज विथ दिस साइड. यहाँ पे सिग्मोइड कोलॉन है ना, तो मैं सिग्मोइड कोलॉन के साइड से जाऊंगा ही नहीं, मैं दूसरे साइड से जाऊंगा. मैं पोस्टीरियरली आऊंगा एंड यहाँ पे ऐसे एंटीरियरली जाऊंगा. So basically, this was an anterior plus posterior sling. It was an open sling, not a closed sling. And it was also a static and dynamic. Static क्यों? क्योंकि sacrum को फिर भी attached है. Dynamic क्यों? क्योंकि आगे rectus sheath को attached है यहाँ पे. This ensured that first of all closed loop नहीं है. Closed loop का there was a problem that there was a possibility of bowel getting herniated and strangulated inside it, which is one side effect that was removed by this open sling. Secondly, it saved the problem of going through the sigmoid mesentery, and hence it was an easier surgery to do. But still, यहाँ पे there is psoas major muscle, which a few surgeons were finding it difficult to go across, which is why again Virkud's composite sling is not preferred. And the most preferred surgery today, and the one that is often done, is Purandare's cervicopexy because of the ease of operation despite all the side effects. So these were three of the major sling surgeries. There are a few more surgeries that you need to know the names of. One is Khanna's sling surgery. खन्ना सेड कि मैं बहुत ज्यादा शाना हूं, मैं क्या करूंगा. प्यूबिक सिम्फाइसिस है, सेक्रम है, यहाँ पे एएसआईएस है, एंटीरियर सुपीरियर इलियक स्पाइन, यहाँ पे बीच में यूट्रस है. He said that I would attach my sling to this anterior superior iliac spine. Very easy surgery, but the problem is anterior superior iliac spine is very close to the skin, and this Mercilin tape would get exposed to the skin, and that would lead to periostitis. Periostitis is basically inflammation of the periosteum. It can be very painful, and वहाँ पे osteomyelitis भी हो सकता है, which is why this procedure is not preferred. This was Khanna sling. देयर वाज ऑल्सो सुना वाला स्लिंग. सुना वाला स्लिंग उसने बोला कि मैं सिर्फ एक साइड पे करूंगा पोस्टीरियरली. उसने बोला सिर्फ राइट साइड पे मैं पोस्टीरियरली करूंगा सो दैट सिग्मोइड कोलॉन को मैं अफेक्ट नहीं करूंगा. बट द प्रॉब्लम विद दिस स्लिंग वाज दिस वाज पुलिंग द यूट्रस टू वन साइड एंड वाज डिस्टॉर्टिंग द एनाटॉमी, व्हिच इज व्हाई इवन सुना वाला स्लिंग सर्जरी इज नॉट प्रेफर्ड. The last type of surgery is Joshi sling, which you don't need to know because it is completely obsolete at this stage. This is all about sling surgeries. Does anyone have any doubt at this point? Any doubt? These are all the surgeries that you do in young women who are having prolapse. Uterine prolapse हो सकता है या फिर cervical elongation हो सकता है. Does anyone have any doubt? अनफॉर्चुनेटली एल्डरली वाला जो है क्वेश्चन वो मुझे कल या परसों कवर करना पड़ेगा. आई वुड नॉट बी एबल टू कवर इट टुडे. कैन यू रिपीट सुना वाला? सुना वाला स्लिंग कुछ नहीं है. इट इज बेसिकली बिटवीन द सेक्रम एंड द यूट्रस बट ओनली ऑन द राइट साइड. इट इज नॉट ऑन द लेफ्ट साइड. सो इट इज अ सेमी सर्कल. इट इज नॉट इवन अ कंप्लीट सर्कल. आधा सर्कल है वो. Psoas hitch is done with surgery. Psoas hitch is done for Suna for Shirodka surgery. हम लोग को psoas मसल में से एक लूप निकाल के जाना पड़ता है. So psoas hitch is done for that. Psoas hitch is also done wherein there are lower ureteric injuries and I have to hitch the bladder onto the psoas muscle so that जो ureter नीचे का इंजोर हुआ है वहां पे रिप्लेस करने के लिए मैं ब्लैडर को ऊपर खींचता हूँ और psoas मसल पे उसको मैं ये भी बोलता हूँ बोआरी फ्लैप भी बोलता हूँ. क्रिएशन ऑफ द बोआरी फ्लैप along with psoas hitch. Why infertility in Purandare? Because there is a retroversion that is created. Retroversion say the sperm finds it difficult to navigate the retroverted uterus. It is not an anatomical position. So did everyone understand both these important topics today? Prolapse in young and tuberculosis, genital tuberculosis. Does anyone have any doubts at this point? Unfortunately, I'll have to cover round ligament is done in all पुरंदरे sling. All पुरंदरे मतलब पुरंदरे एक ही sling का सर्जरी है. बाकी लोग में नहीं करते, हम सिर्फ पुरंदरे में करते हैं. It is only where there is retroversion that is expected. उसको correct करने के लिए हम round ligament plication करते हैं. बाकी के सर्जरीज में जरूरत ही नहीं है ना. एंड यस, इन ऑल द पुरंदरे पेशेंट्स में हमें करना ही है, डेफिनेटली यस. So that's it from my end tonight. Thank you so much, everyone. I will have to won't you have to do mug hack appearance in PID? Won't have to do. Thank you. Won't have to mug HSG appearance. Won't have to mug. Oh, मेरे को कुछ लगा ये नया कोई तो appearance आ गया MCQs में. Mug HSG appearance. Oh yeah, absolutely. Now you have understood the reasons why there are all those changes that happen in patients with PID, especially pelvic tuberculosis. I hope you understood the reasoning behind each and every change that happens in women. Can sling surgery help in cervical elongation? Absolutely not. The problem with cervical elongation is that cervix लंबा है. Uterus is still in its position. Uterus के जगह को कुछ हुआ ही नहीं है. तो sling surgery करके मतलब क्या है? Sling surgery is only done when the uterosacral ligaments are completely damaged और पूरा uterus नीचे आ रहा है. So there is no point of doing sling surgery in cervical elongation. Oh, hi, Paurus. I'm hearing you are being a great intern in OBGYN in KEM. Glad to have you tonight. So thank you so much, everyone. Good night. Unfortunately, within 1.5 hours, we could cover only two small topics, but they are very significant. Exam में बहुत लोग मार खा जाते हैं sling surgeries and Manchester for the Gill में. If you all want, let me know. I have taken each and every picture of Manchester for the Gill repair जो कहीं पे भी कोई books में नहीं मिलेगा. I can send those pictures to you with the description if you all need it. Just text me after this session. So thank you so much, everyone, and then good night. It's goodbye from my end. This is Dr. Aditya signing off. Good night, and we shall see each other very soon. I think I'll take two more sessions. एक में prolapse ही चलता रहेगा, and I had to discuss fibroids as well, which we couldn't discuss today. But yeah, I'll get back with it probably tomorrow or maybe next week or on this Sunday. So until then, this is me signing off. Good night.